Bismillahirrahmanirrahim. Today we will discuss antepartum hemorrhage, the RCOG guideline number 63, which was published in November 2011. The first point in this guideline is about prediction and prevention of antepartum hemorrhage. So, what are the risk factors for placental abruption? The most predictive is abruption in previous pregnancy. There is 4.4% incidence of recurrent abruption. Abruption recurs in 19 to 25% of women who have had the previous two pregnancies complicated by abruption. The other risk factors include preeclampsia, fetal growth restriction, non-vertex presentation, polyhydramnios, advanced maternal age, multiparity, low body mass index, pregnancies following the assisted reproductive techniques, intrauterine infections, premature rupture of membranes, abdominal trauma both accidental and resulting from domestic violence, smoking and drug misuse, first trimester bleeding, maternal thrombophilias like factor V Leiden, and heterozygous prothrombin gene mutation. What are the risk factors for placenta previa? The risk factors for placenta previa include previous placenta previa, previous cesarean sections like 1, 2, or 3 previous cesarean section, increase the risk of placenta previa with the odd ratio of 2.2, 4.1, and 22.4 respectively. Previous termination of pregnancy, multiparity, advanced maternal age of more than 40 years, multiple pregnancy, smoking, deficient endometrium due to the presence of the history of uterine scar, endometritis, manual removal of placenta, curettage, submucous fibroid, and assisted conception. Can APH be predicted? APH has a heterogeneous pathophysiology and cannot reliably be predicted. Can APH be prevented? Women should be advised, encouraged, and helped to change the modifiable risk factors such as smoking and drug misuse. And there is limited evidence to support interventions to prevent antepartum hemorrhage. Let us talk about special advice in case of hemorrhage from placenta previa. It is considered good practice to avoid vaginal and rectal examination in women with placenta previa and to advise these women to avoid penetrative sexual intercourse. Now, what are the complications of antepartum hemorrhage? The complications include, first of all, the maternal complications like anemia, infection, maternal shock, renal tubular necrosis, consumptive coagulopathy, postpartum hemorrhage, prolonged hospital stay, psychological sequelae, complications of blood transfusion. The fetal complications of APH include fetal hypoxia, small for gestational age and fetal growth restriction, prematurity, which include both iatrogenic and spontaneous premature baby, and the fetal death. Is APH associated with any specific pregnancy complications and outcome? Health professionals should be aware that domestic violence in pregnancy may result in APH. Antepartum hemorrhage is associated with maternal and perinatal morbidity and mortality. Clinicians managing women with APH should be aware of these potential consequences. Now, where should the woman presenting with APH be managed? It is recommended that women should be advised to report all vaginal bleeding to their antenatal care provider. Women with APH presenting to a midwifery-led maternity unit, a general practitioner, or to an accident and emergency department should be assessed, stabilized if necessary, and transferred to a hospital maternity unit with facilities for resuscitation such as anesthetic support and blood transfusion resources and performing emergency operative delivery. A multidisciplinary team, including midwifery and obstetric staff, with immediate access to laboratory, theatre, neonatal, and anesthetic services, should provide clinical assessment. Now, what is the role of clinical assessment in women presenting with APH? The role of clinical assessment in women presenting with APH is first to establish whether urgent intervention is required to manage maternal or fetal compromise. The process of triage include history taking to assess coexisting symptoms such as pain, and assessment of the extent of vaginal bleeding, the cardiovascular condition of the mother, and an assessment of fetal well-being. And if there is no maternal compromise, a full history should be taken. The clinical history should determine whether there is pain associated with the hemorrhage or not. Placental abruption should be considered when the pain is continuous. Labor should be considered if pain is intermittent. Risk factors for abruption and placenta previa should be identified. The woman should be asked about her awareness of fetal movements, and attempts should be made to auscultate the fetal heart. If APH is associated with spontaneous or iatrogenic rupture of membranes, bleeding from ruptured vasa previa should be considered. Previous cervical smear history may be useful in order to assess the possibility of neoplastic lesion of the cervix as the cause of bleeding. The presentation of cervical cancer in the pregnancy depends upon the stage at diagnosis and the lesion size. Most women with FIGO stage 1 cancer are asymptomatic. Examination of the woman should be performed to assess the amount and cause of APH. All women presenting with APH should have their pulse and blood pressure recorded. Next comes the abdominal palpation. The woman should be assessed for tenderness or signs of an acute abdomen. The tense or woody feel to the uterus or an abdominal palpation indicate the significant abruption. Abdominal palpation may also reveal uterine contractions. A soft, non-tender uterus may suggest lower genital tract cause or bleeding from placenta or vasa previa. Next comes the speculum examination. A speculum examination can be useful to identify cervical dilatation or visualize a lower genital tract cause for the APH. Next comes the digital vaginal examination. If placenta previa is a possible diagnosis, for example, previous scan shows a low placenta, there is a high presenting part on abdominal examination, or the bleed has been painless, the digital vaginal examination should not be performed until an ultrasound has excluded the placenta previa. Digital vaginal examination can provide information on cervical dilatation if APH is associated with pain or uterine activity. What investigations should be performed in women presenting with APH? First of all, maternal investigations. Investigations should be performed to assess the extent and physiological consequences of the APH. The maternal investigations performed will depend on the amount of bleeding. First of all, the Kleihar test. That should be performed in rhesus D negative to quantify the fetal-maternal hemorrhage in order to gauge the dose of the anti-D immunoglobulin required. But the Kleihar test is not sensitive for the diagnosis of abruption. Ultrasound can be used to diagnose placenta previa but doesn't exclude the abruption. Placental abruption is a clinical diagnosis and there is no sensitive or reliable diagnostic test available. Ultrasound has limited sensitivity in identification of retroplacental hemorrhage. Next comes the use of different blood tests. In case of major or massive hemorrhage, the blood should be analyzed for full blood count and coagulation screen and 4 units of blood cross-matched. Urea, electrolyte and liver function tests should be assessed. The initial hemoglobin may not reflect the amount of blood lost, and therefore clinical judgment should be used when initiating and calculating the blood transfusion required. In such circumstances, a point of the care test, bedside test to assess the hemoglobin may be useful. The platelet count, if low, may indicate the consumptive process seen in relation to the significant abruption. This may be associated with a coagulopathy. The ultrasound scan. Women presenting with APH should have an ultrasound scan performed to confirm or exclude the placenta previa. If the placental site is not already known, placental scanning is well established in determining the placental location and in the diagnosis of placenta previa. Next comes the fetal investigation. An assessment of fetal heart rate should be performed using the CTG in women presenting with APH. And whenever possible, CTG monitoring should be performed where knowledge of fetal condition will influence the timing and mood of delivery. Next comes the ultrasound. That should be carried out to establish the fetal heart pulsation if fetal viability cannot be detected using external auscultation. Now, should women with APH be hospitalized, and if so, for how long? Women presenting with spotting who are no longer bleeding and where placenta previa has been excluded can go home after reassuring the initial clinical assessment. All women with APH heavier than spotting and women with ongoing bleeding should remain in hospital at least until the bleeding has stopped. Now, should corticosteroid be administered to women who present with APH before term? Clinician should offer a single course of antenatal corticosteroid to the woman between 24 and 34 plus 6 weeks of gestation at the risk of preterm birth. In women presenting with spotting, where the most likely cause is lower genital tract bleeding, where the imminent delivery is unlikely, the corticosteroids are unlikely to be of benefit but could still be considered. Now, should tocolytic therapy be used in women presenting with APH who have uterine activity? Tocolysis should not be used to delay delivery in women presenting with a major APH or who has hemodynamically instability, or if there is evidence of fetal compromise. A senior obstetrician should make any decision regarding the initiation of tocolysis in the event of an APH. Should the antenatal care of a woman be altered following APH? Following single or recurrent episode of APH from cervical ectropion, subsequent antenatal care need not to be altered. Following APH from placental abruption or unexplained APH, the pregnancy should be reclassified as high risk and antenatal care should be consultant-led. Serial ultrasound for the fetal growth should be performed. Next comes the labor and delivery. When should women with APH be delivered and what mode of delivery should be employed in women whose pregnancies have been complicated by APH? First of all, if the fetal death is diagnosed, vaginal birth is recommended mode of delivery for the most of the women. If fetus is compromised, a cesarean section is appropriate method of delivery with concurrent resuscitation of the mother. Women with APH and associated maternal or fetal compromise are required to be delivered immediately. The optimum timing of delivery of women presenting with unexplained APH and no associated maternal or fetal compromise is not established. A senior obstetrician should be involved in determining the timing and mode of the birth in these women. Now, what intrapartum fetal monitoring should be employed for the women whose pregnancies were complicated by APH? Women in labor with active vaginal bleeding require continuous electronic fetal monitoring. In women who are in preterm labor, whose pregnancies have been complicated by major APH or recurrent minor APH, or if there has been any clinical suspicion of abruption, then the continuous CTG monitoring should be recommended. In women who have experienced one episode of minor APH in which there have been no subsequent concern regarding the maternal or fetal well-being, intermittent auscultation is appropriate. Women with a minor APH with evidence of placental insufficiency such as fetal growth restriction or oligohydramnios should be recommended to undergo the continuous electronic fetal monitoring. Now, what is the optimal mode of anesthesia for the women who have experienced APH? Regional anesthetic is recommended for operative delivery unless there is specific contraindication. In a case of APH where maternal or fetal condition is compromised and cesarean section is required, a general anesthetic should be considered to facilitate the control of maternal resuscitation and to expedite delivery. A consultant anesthetist should be involved in the intrapartum care of the woman with APH with associated compromise. Now, what is the appropriate management of third stage of the labor in women with APH? First of all, postpartum hemorrhage should be anticipated in women who have experienced APH. Women with APH resulting from placental abruption or placenta previa should be strongly recommended to receive the active management of third stage of the labor. Consideration should be given to the use of ergometrine oxytocin combination or symptometrine to manage the third stage of the labor in women with APH resulting from placental abruption or placenta previa in the absence of hypertension. Now, should women presenting with APH who are RHD negative be given anti-D immunoglobulin? Anti-D immunoglobulin should be given to all the non-sensitized RHD negative women after any presentation with APH, independent of whether routine antenatal prophylactic anti-D has been administered or not. In the non-sensitized Rh-D negative woman, in the event of recurrent vaginal bleeding after 20 weeks of gestation, anti-D immunoglobulin should be given at a minimum of 6-weekly interval. In the non-sensitized Rh-D negative woman, for all event after 20 weeks of gestation, at least 500 international unit anti-D should be given, followed by a test to identify fetal-maternal hemorrhage greater than 4 ml red blood cells. Then, in that case, additional anti-D should be given as required. Now, how should massive APH be managed, and who should be included in the resuscitation team? The management of massive APH should follow locally devised multidisciplinary team protocols for massive obstetric hemorrhage. The management team should include a consultant obstetrician, anesthetist, hematologist, and midwifery labor ward coordinator. Laboratory staff and portering staff should be alerted. Now, what blood products should be ordered and made available for women with APH? In the management of military trauma, a decrease in coagulopathy and improved survival is reported with a high fresh frozen plasma to packed red cells transfusion ratio of 1:1 to 1:1.4. An observational population-based study compared the transfusion of whole blood versus packed red cells in the obstetric hemorrhage. What are the side effects? Women who were transfused with packed red cells developed acute tubular necrosis more often than women given whole blood, while pulmonary edema was more commonly seen in women given the whole blood. Prospective randomized trials are required before recommendations can be made on the whole blood transfusion in the obstetric hemorrhage. Now, how should the woman presenting with an APH who develops a coagulopathy be managed? In a woman who have experienced a massive blood loss or a major abruption, the development of DIC should be considered. Coagulation studies and the platelet count should be urgently requested and advised from hematologists sought. Up to 4 units of FFP and 10 unit cryoprecipitates may be given whilst awaiting the result of coagulation studies. Now, how should the woman presenting with an APH who is taking anticoagulant therapy be managed? Women receiving antenatal anticoagulant therapy, usually low molecular weight heparin or warfarin, should be advised that if they have any vaginal bleeding, they should not take any more doses of anticoagulant medications. They should attend the hospital urgently, be assessed on admission, and further doses should be administered after consultation with the medical staff. In women whose pregnancy is complicated by the APH, how should the neonate be managed and by whom? Major or massive APH may result in fetal anemia and fetal compromise. The neonate should be assessed by a senior pediatrician or neonatologist. In minor APH, the clinical judgment should be sought. With the continuing hemorrhage, it would be appropriate to request the pediatric support at the time of delivery. How should the woman with extremely preterm pregnancy, like between 24 to 26 weeks of gestation, and APH be managed? Regardless of the gestation, the mother's life should be given priority. She should be resuscitated and stabilized before any decision is made regarding the delivery of the baby. A senior pediatrician and neonatologist should be involved in the counseling of the woman when extreme preterm birth is likely. Now, what are the postnatal issues that need to be addressed in women whose pregnancies are complicated by APH? The postnatal management of pregnancies complicated by major or massive APH should include thromboprophylaxis, debriefing, and clinical incident reporting. What is the role of obstetric skill drills to improve the management of APH? Management of major APH should be included in obstetric skill drills. Let us talk about the principles of management of massive APH, that is blood loss greater than 1000 ml or signs of clinical shock. The personnel required are first of all the midwife, secondly obstetric middle grade and consultant obstetrician, anesthetic middle grade or consultant, hematologist. The blood transfusion laboratory should be alerted in such case. Call porters for the delivery of specimens or blood, and designate one member of the team to record the events like fluid, drugs, and vital signs during such event. What is the principle of management of APH? Initial management should follow the ABCD pathway. A and B means assess airway and breathing. A high concentration of oxygen of 10 to 15 liters per minute is given via the face mask. C means evaluate the circulation. Established two 14 gauge intravenous lines and 20 ml of the blood sample should be taken for the different tests. And we need to arrange at least 4 units of the blood after cross match. D means assess the fetus and decide on the delivery. The 4 pillars of management include, first of all, communication between all members of multidisciplinary team. Secondly, resuscitation. Thirdly, monitoring and investigation. And fourthly, arrest bleeding by arranging delivery of the fetus. The basic measures for hemorrhage up to 1000 ml with no clinical shock include, first of all, intravenous access with the 14 gauge cannula and commence crystallite infusion. The full protocol for the massive hemorrhage with a blood loss of more than 1000 ml or clinical shock include, first of all, assess the airway, assess breathing, evaluate circulation, oxygen by mask, intravenous access, position left lateral, keep the woman warm and transfuse blood until the blood is available. Give 3.5 liter of warm crystallite or colloid as rapidly as required, and the best equipment available should be used to achieve rapid warm infusion of the fluid, and special blood filters should not be used as they slow the infusion. Now this chart from the guideline show the fluid therapy and blood product for the transfusion, which include the crystallite, colloid, blood, fresh frozen plasma, platelet concentrates, the cryoprecipitates. So the therapeutic goals are to maintain hemoglobin of more than 8 gram per liter, platelet count of more than 75 cross 10 raised to power 9 per liter, prothrombin less than 1.5 cross mean control, activated partial thromboplastin time less than 1.5 cross mean control, fibrinogen of more than 1 gram per liter. So that was all about the antepartum hemorrhage RCOG guideline. Thank you so much. Subscribe on Obs and Gynae. Allah Hafiz.